So here we have a high-resolution chest CT, which shows basilar predominant pulmonary fibrosis. And so let me just scroll through to show you that indeed it is basilar predominant. In the areas of lungs that are less severely affected, it does look to be peripheral predominant, and there are clear areas of subpleural honeycombing. So we call honeycombing when we see these subpleural cysts, which either line up in rows, and really two cysts are enough in the most subpleural portion of lung to call honeycombing. And when they start to stack upon each other, we actually see perhaps a little bit of stacking here. We have a more definitive example of honeycombing. But there is certainly honeycombing on this CT scan. So we get down to lung bases, the fibrosis certainly becomes much more confluent, and there is exuberant traction bronchiectasis as well as lower lobe volume loss. So minor fissures pulled back here, and certainly there's architectural distortion here at the lung bases. So based on this coarseness, based on the honeycombing, there's a little bit of ground glass opacity in some areas, but I think you really have to look at the major pattern on HRCT, and the major pattern here is that of HRCT. But based on the lung morphology, you would say that this is a UIP pattern of pulmonary fibrosis. But now we have to be careful. UIP, some people think is synonymous with idiopathic pulmonary fibrosis, and we know that it's not the case. We know that UIP can be secondary to other disease processes, especially certain types of connective tissue disease, like rheumatoid arthritis. Could also be due to hypersensitivity pneumonitis. You could also see it from drug-related pulmonary fibrosis as well. So what do? We can look at the coronal plane, and we see that the patient has this straight edge morphology. So with this cursor, we can draw the interface between what normal and abnormal lung is using a relatively straight line. We do it on both sides. And it's probably better to do it something like this, or relatively straight. And that tells you that even though this is a UIP pattern of pulmonary fibrosis, this is highly likely to be due to connective tissue disease. And so this is actually a nice lesson. This patient actually has a comparison CT, actually a CTA from 2017. The study we were looking at was from this year. And so if we look carefully at this CT, again, the CTA for pulmonary embolism was not done full inspiration because we don't do that for our PE studies. But we see that in the lung bases, it looks like there was plenty of consolidation and ground glass opacity, but not much frank fibrosis. Maybe one would question if there was fibrosis based on the traction or the bronchiectasis, which one would question would be traction subtype. But this looks mostly like ground glass opacity and consolidation. So if we look at the coronal reformation, which I'll bring up right here, back here as well, we see that straight edge morphology, the straight edge sign. And so the straight edge sign is associated with connective tissue disease, histologically also associated with NSIP. So what am I getting at here? I think this is a nice example, and this is, I think, not very well described, but certainly has been described in the literature, of an NSIP pattern, shown here in 2017, evolving into more of a UIP pattern of pulmonary fibrosis. The straight edge sign really on the 2020 study is the indicator that you're dealing with a connective tissue disease case, in this case shown to represent actually rheumatoid arthritis that perhaps emanated from an NSIP pattern. So this is the value of looking at the coronal reformations and specifically looking for the straight edge sign. Also, for those of you guys who have hawk eyes, you guys probably also noticed that if you look in the mediastinum, the esophagus is dilated. There's a gas fluid level here in the esophagus. And so that certainly supports a diagnosis of esophageal dysmotility, which can be seen in connective tissue disease.